Thank you very much. So this topic is another iceberg, really, a huge amount that could be covered. And rather than not do it justice by trying to cover too much, what I thought I would do is describe how the identification and general pathways around cardiomyopathies are evolving in the UK and more widely with guidelines. Look at some specific cases and some issues and update you on some issues related to cases in specific cardiomyopathies and take it on from there. So one of the things that we've noticed is that we're increasingly recognizing cardiomyopathies both through increased identification of patients with heart failure and by increasing use of more complex imaging, particularly cardiac MRI. So in the UK, we have the NICE guidelines, which we've mentioned earlier in the morning sessions, and as well as describing what treatments should be available and how to apply them, they describe how we should, how our pathways for identifying patients should be structured, and the chronic heart failure guidelines, which are a few years old now, set out how patients with suspected heart failure should be managed, how they should be referred on, how they should be identified. So these are for outpatients with heart failure. If a patient is suspected to have heart failure and they have a previous history of myocardial infarction, then they're referred to the hospital and will be seen by a heart failure specialist for an assessment and an echocardiogram within 2 weeks. If the patient has suspected heart failure and no prior diagnosis of MI, then the GP, the primary care physician, will do an NT-proBNP, and if that is greater than 400, we'll see the patient within 6 weeks of referral. If the NT-proBNP is very high, higher than 2,000, again, we'll see them within 2 weeks. And those timeframes are not really based on any specific evidence, but it's really a recognition because there's of the fact that there's a poor prognosis associated with untreated heart failure, and patients with prior MI or very high BNP are at particularly high risk of decompensating, becoming unwell, being admitted to hospital, and mortality. So this has, over the past few years, been implemented in the UK and led to a more standardized approach to the diagnosis and investigation of patients with heart failure. And rather than patients with heart failure and therefore potentially cardiomyopathy just turning up in any general cardiology clinic, they tend to get funneled into people with specialist knowledge and expertise in heart failure who can then improve how they run the services even further by seeing more of these patients. So it's self-fulfilling, really, having these pathways in place. Again, the definition of a heart failure specialist is just somebody with a special interest in heart failure. It doesn't have to be a consultant cardiologist, but the vast majority of times it will be. So as part of this pathway in Queen Alexandra Hospital in Portsmouth, where I work, we're now seeing around 10 new patients a week, which is increasing. We know that historically there's been an underdiagnosis of patients with cardiomyopathies and heart failure in primary care. So we are now seeing an increasing number of those coming through via this pathway. Of the patients who we see in clinic with suspected heart failure, once we've seen them and assessed them and have the benefit of an ECG and an echo, we feel that around 50%, or we know that around 50% of those patients will actually have heart failure. Of that 50%, that breaks down fairly easily into around 50% with left ventricular systolic impairment, and around 50% have heart failure with preserved ejection fraction. So pretty well in keeping with published data on the prevalence of heart failure. As I was talking about earlier, many of those patients will have MRI scans as part of their workup, I would say most patients with LVSD and selected patients with heart failure and a preserved ejection fraction will get referred on for a cardiac MRI. So I'm going to go through a couple of cases now of patients who presented over the last year or so to our heart failure unit, either via this outpatient pathway or have presented as inpatients. So the first case is a 72-year-old man who had a background of hypertension and an ECG showing long-standing left bundle branch block. He'd actually been evaluated a couple of years prior for this, for breathlessness and abnormal ECG, and he'd had an echo which had shown good left ventricular systolic function, biatrial dilatation, moderate concentric LVH, and at that point he was diagnosed with hypertensive heart disease and discharged with a recommendation that he have good control of his blood pressure. Unfortunately, he never really felt much better and eventually came back to us via this pathway with progressive breathlessness and an NT-proBNP of greater than 5,000, so very high. On probing a little bit further when he came this time, he actually had a history of bilateral carpal tunnel repair in addition to hypertension. And we repeated the echo, which didn't look vastly different. There was moderate concentric left ventricular hypertrophy, good systolic function, but evidence of significant diastolic impairment and restrictive physiology. So we were not much the wiser. We were not sure really still what was going on at that stage, so he had a cardiac MRI. The top images here show the cines. These are stills rather than movies. The first one is in end diastole and the second one in end systole, showing concentric left ventricular hypertrophy. There's also hypertrophy of the intraatrial septum and biatrial enlargement. And then we went on to perform late gadolinium enhancement imaging, and this shows diffuse subendocardial hyperenhancement here where the arrows point out. And in the short axis view, so this is a short axis view of the left ventricle, again diffuse, widespread late gadolinium enhancement, largely sparing the septum in this case. And these are typical appearances that we see with cardiac amyloid. This patient was relatively young and went on and had a myocardial biopsy here. She had an LV biopsy in this case because the RV and the septum looked fairly normal, which confirmed subendocardial amyloid deposit on the microscopy, and also the typical apple green birefringence when viewed under high intensity Congo red stain with cross-polarized light with Congo red staining. So a nice case illustrating the fact that one of the advantages in concentrating expertise and doing more MRI in these patients with heart failure is that we're increasingly recognizing cardiac amyloid. It is an uncommon disease, but perhaps not quite as uncommon as we've previously thought. It's a multi-system disease caused by deposition of misfolded proteins in organs and tissues. There are multiple types, but as cardiologists, the main two types that we have to worry about or think about are AL amyloid and transthyretin or TTR amyloid. And the reason that we need to know about them is because a lot of the morbidity and mortality in patients with amyloid, these types of amyloid, is related to the heart and heart failure. Previously, I think we tended to underestimate the prevalence of these cases, and we're now seeing them much more commonly. AL amyloid is, of course, the light chain of the immunoglobulin becomes misfolded and deposited in the tissue, as compared to, and transthyretin amyloid is divided into a hereditary type, which is rare, apart from in Afro-Caribbeans where it's much more prevalent, and a wild type, which is really an age-related amyloid, previously known as senile amyloid. I find the patients much prefer it if you call it wild type amyloid to senile amyloid when you're telling them what the diagnosis is. Now, at autopsy, if we look at patients over the age of 80 who have a post-mortem and cardiac investigation, 25% of patients have wild-type TTR amyloid present. Although the clinical significance of this is unsure, is unclear really, I think that underpins the point that we're tending to, this is a condition that we've tended to underdiagnose, and one that if you look for it, you will find it. Wild-type TTR amyloid is actually predominantly a disease of a cardiomyopathy with carpal tunnel syndrome. That's those are the predominant clinical features, despite the fact that there's multi-organ deposition of the protein. So, how can we better identify these patients? One common misconception is the ECG in amyloid. So the ECG is usually abnormal in some way. Traditionally, we've described this as being low voltage complexes with poor R-wave progression, a pseudo-infarct pattern on the ECG. However, with increasing recognition of amyloid, we now recognize that this pattern is only present in maybe up to 50% of people with AL amyloid, and far fewer with TTR amyloid, maybe around 25%. The sort of things we look for on MRI scanning are, of course, the atrial and the ventricular size, large atria, normal left ventricular sizes with increased wall thickness. It's very common to see small pleural and pericardial effusions, but the key is really the late gadolinium enhancement imaging. When you see a report saying that there's abnormal gadolinium kinetics, that is very suggestive of cardiac amyloid. What does that mean? Well, the reason that gadolinium kinetics are altered is because there's so much abnormal protein deposited within the myocardium. At the time of taking the late gadolinium images, there is more protein, there is more gadolinium, more contrast in the myocardium than there is in the blood. And normally the opposite will be true. Normally there's much more gadolinium contrast in the blood and less in the myocardium. So when you're trying to null the myocardium to make the normal images, the normal areas of myocardium black, that becomes very difficult. People get very confused, start wondering what's going on and whether they've taken the images properly until really it clicks that this is amyloid. And although that's very suggestive of a diagnosis of amyloid, the converse is not true. If you don't see that, you cannot rule out amyloid. As I mentioned previously, T1 mapping is increasingly used and is very abnormal in amyloid. Endomyocardial biopsy, of course, remains the gold standard. With AL amyloid, you can often find an extra cardiac site to biopsy to confirm the diagnosis, such as fat, bone, or kidneys. But with TTR amyloid, you're much more likely to have to proceed to myocardial biopsy because of the lower diagnostic yield from looking elsewhere. So the question is, with cardiac MRI and amyloid, could it be used as a non-invasive biopsy? Could we use this instead of going on towards a cardiac biopsy, which has more limited availability and obviously carries some risk of complications? So there was one UK study of 51 patients, which doesn't seem many, but obviously amyloid, there are not huge numbers of amyloid patients around, at least that we've identified so far. And they compared the pattern of late gadolinium enhancement in TTR amyloid to AL amyloid. And they found that these patients with TTR amyloids, this was wild-type TTR amyloid, had a higher LV mass, more late gadolinium enhancement. The enhancement tended to be transmural. There was often enhancement involving the right ventricle as well as the left ventricle. All this was actually quite surprising because the prognosis of AL amyloid tends to be much worse than wild-type TTR amyloid, which has a much more indolent course. So using this information, they developed a scoring system, a late gadolinium enhancement scoring system from the MRI scans, and were pretty accurate in being able to differentiate AL amyloid from wild-type TTR amyloid on the MRI scan with an 87% sensitivity and 96% specificity. Obviously, this is a small study, but of great interest and an area that is likely to continue to, where we're likely to continue to see further data in future. So the management of patients with cardiac amyloid. These patients, of course, have a very restrictive physiology and a very fixed stroke volume. So they often develop significant edema and heart failure symptoms. So we do need to treat them with diuretics, cautious use of diuretics to improve their symptoms and to make them feel better. As the disease progresses, LV systolic function often will become impaired. And in contrast really to lots of other cardiomyopathies and heart failure, when LV systolic function is impaired, ACE inhibitors and beta blockers are often poorly tolerated. They have a fixed stroke volume. There's often autonomic dysfunction as well that goes with amyloid, and therefore patients tolerate vasodilatation and lowering of heart rate very poorly. So we try to get these drugs in at low doses, at least early on, but more often than not, we find that we're having to stop these drugs in patients as their amyloid progresses. Treatments of amyloid are also progressing, and AL amyloid does actually have some treatments available now. They tend to be hand-me-downs from the treatment of myeloma, but there are drug treatments available and occasionally autologous peripheral blood stem cell transplants after radiation therapy, after chemotherapy. TTR wild-type amyloid tends to follow a more indolent course, especially in men who predominantly get the disease. However, there are new drugs entering trials now, some of which I've put the names up there, already have approval for hereditary TTR amyloid and may go on to get approval for wild-type amyloid. I'll move on to the next case. So this patient's a 54-year-old man who had diabetes who came into hospital with chest pain, which is obviously not uncommon. He was noted to have complete heart block and a small troponin rise. So the first question was whether he had coronary disease and that had caused the conducting tissue disease. So he had an emergency dual chamber pacemaker first of all because of the complete heart block with high risk features, and he then went on to have an angiogram which showed only mild coronary disease. He had an echo at the time which was reported as being normal. The diagnosis was never completely clear, but he was discharged. He then represented with ongoing breathlessness and was sent to the respiratory team, who performed a CT scan which was suggested of pulmonary sarcoid. They treated his pulmonary sarcoid with steroids, and his lung function tests improved, but he remained very breathless. They repeated the echo at this stage, which was only a few months down the line, and at that time LV function had deteriorated and was now only moderate. He had a pacing check around the same time showing non-sustained ventricular tachycardia. And at this point, he came back into the cardiology services for further assessment. That looks slightly unusual now. You'll remember this patient had a pacemaker, but the person who put it in had the foresight to implant a MRI conditional system. So on the right there you have a picture of one of the planning pictures of the heart, and you see this black hole, which is what you see when you image patients with pacemakers, and the RV lead is visible as a black mark within the RV. So an implantable device, if they have a system which is proven to be conditional with MR, is no longer a contraindication to MRI scan. Luckily he had one. We were able to go on and finish the study. There's a four-chamber view showing that LV function is impaired, and then some late gadolinium enhancement, showing this patch of mid or sub-epicardial late gadolinium enhancement affecting the septum. It's bright, it's focal, and this would be typical of what we'd see with cardiac sarcoid. Again, can affect the basal infralateral wall, but also the septum, which is presumably why there's a high instance of AV block in these patients. So, in relation to that, last year, the Heart Rhythm Society of the United States actually published some guidelines or a consensus statement on the diagnosis and management of arrhythmias associated with cardiac sarcoidosis. And in these guidelines, they give advice about the diagnosis of cardiac sarcoid, screening for patients who could potentially have cardiac sarcoid, risk stratification for sudden death, arrhythmia management, and some discussion around who should have ICDs. Again, of course, largely expert opinion rather than truly evidence-based, but a very useful expert statement nonetheless. So patients under the age of 60 who have unexplained Mobitz 2 or 3 heart block, it is recommended that we look a little bit harder for sarcoid in these patients. And the recommendations are that these patients have a high-resolution CT scan of the chest and also some advanced cardiac imaging, which is either cardiac MRI or FDG PET, cardiac PET. And if either of those are abnormal, it's likely that that patient has cardiac MRI, has cardiac sarcoidosis, and biopsy evidence should be sought either from an extracardiac, if possible, an extracardiac site, or from a cardiac site. And the patient we just talked about, of course, fitted into these criteria. In response to these sorts of patients and these guidelines coming out, we've set up another multidisciplinary team. You'll think that's all we do is multidisciplinary teams in Portsmouth, but we've set one up with the respiratory team, so we work very closely now to allow better identification of these patients with the respiratory team. Again, there's a dedicated physician within respiratory medicine with an interest in sarcoid, 2 of us from cardiology with an interest, where we can refer patients back and discuss patients. And we're relatively new at this, so we've formed links with one of the London hospitals who have even more expertise, and we can feed patients in there as and when required. And equally, we don't have access to cardiac PET, and we can refer the occasional patient on for cardiac PET. I might just skip that as time is running out. In terms, as a cardiologist who implants ICDs, one other part of this guideline that was of particular interest to me is that the guideline says that any patient with cardiac sarcoid who has a bradycardia indication for pacing should be considered for an ICD, and that's given a class 2A indication. And also, if after a period of treatment with appropriate drugs for LV systolic dysfunction and immunosuppression if required, left ventricular function or right ventricular function remains impaired, these patients should be considered for an ICD, a primary prevention ICD. That's only given a 2B indication, but the thresholds, the ejection fraction thresholds are different than in the general cardiomyopathy and heart failure population. I'll move on to the last patient. So this is a 46-year-old man, and it's an interesting case. He's fit and well, and his job was to go around companies, big companies in the UK, persuading them to put in automatic defibrillators. There's a program in the UK and in many countries in the world of putting automatic defibrillators, external defibrillators in public places, so they can be accessed at times of emergency. And he persuaded a large company that they should install these, and he went back to see how they were getting along. And lo and behold, as he was asking them how they were getting along, he actually had a VF arrest. So he was brought to hospital, he had an angiogram, he had normal coronary arteries, and spent a period on intensive care before coming into the heart failure service that way. His ECG showed left bundle branch block. I don't have his echo, but his echo showed they had a dilated left ventricle. A comment was made that he had suboptimal image quality because he was quite a big guy, but no specific clues as to the etiology of his heart failure. He went on to have an MRI scan, which I've shown here. He was pretty unwell after his cardiac arrest because he had a fairly prolonged resuscitation, and even by the time of the MRI scan, you can see he's still in heart failure with bilateral pleural effusions. But again, this shows a dilated and severely impaired left ventricle. But what is striking in this patient is this non-compacted myocardium visible along the lateral and inferior walls. So on the basis of these images, we were able to make a diagnosis of dilated cardiomyopathy with left ventricular non-compaction. Here's the scar imaging, and what that shows here is a thin layer of subendocardial scar. So he had also had a previous myocardial infarction, but he had normal coronaries, so this is very likely to be due to an embolic event. So he got treated in the normal way with maximal heart failure medications. He's presented with a cardiac arrest due to VF, so he had an indication for an ICD. He had left bundle branch block and poor left ventricular function, so I implanted a CRTD during the index admission. Because of the diagnosis of left ventricular non-compaction, and particularly given the previous embolic infarct, I anticoagulated him. Usually we would tend to use warfarin for this, for patients such as this. However, because of his job, it involved lots of traveling. He didn't want the inconvenience of INR testing, so we used a novel oral anticoagulant, apixaban, admittedly completely off license in this instance. But he did very well. I saw him for follow-up in clinic. He's gone back to work. He's even more vociferous now in trying to persuade people to put automatic defibrillators in public places. His ejection fraction's improved moderately, and he's awaiting some genetic screening. So left ventricular non-compaction is still a poorly understood pathological process, but again increasingly recognized. It's a morphological abnormality of the left ventricle where there are there's a layer of thin, normal-looking compacted myocardium, and overlying that there's a thick, non-compacted layer of myocardium with deep recesses and trabeculations. These recesses and trabeculations predispose patients to thrombus formation and thromboembolic events such as this patient had. These patients, as well as being predisposed to heart failure, also particularly predisposed to arrhythmias. So he really had a full house of heart failure, arrhythmias, and a systemic thromboembolism. Now, non-compaction is genetically heterogeneous, so the presentation, the phenotype is also extremely varied. Genetic mutations have been identified linked to LVNC, including mutations in sarcomere, cytoskeletal proteins, mitochondrial proteins. So perhaps that explains why non-compaction can be seen on its own or in conjunction with other congenital heart defects, certain genetic syndromes, and any other cardiomyopathies. But what I would say is that the key message for left ventricular non-compaction is to recognize the phenotype and treat it accordingly. So if the patient has a dilated cardiomyopathy phenotype, to treat them as like a patient with dilated cardiomyopathy. Likewise, they can present with a hypertrophic cardiomyopathy picture, treat them as a patient with hypertrophic cardiomyopathy. The diagnosis, there are echo and MRI criteria for diagnosing non-compaction. The MR criteria are very similar to the echo criteria, and you measure how much non-compacted myocardium there is, how much compacted myocardium there is, and work out the ratio between the two, and if that's more than 2.3 in any segment apart from the true apex, that's enough to allow you to make a diagnosis of non-compaction. Although what we do know is that will tend to lead to overdiagnosis if we very strictly apply that criterion. For that reason, it is possible to work out the mass of non-compacted and compacted myocardium and compare those. And if the trabeculated mass exceeds 20% of the global LV mass, then you can make a diagnosis of non-compaction on that basis as well. So, I think I'm out of time. My final slide, emerging fronts in cardiomyopathies. I think I've gone through T1 mapping earlier, and we're likely to see that playing an increasing role in future. Genetics I didn't cover because, again, that's an emerging field and something that we don't understand well at the moment, but is likely to become increasingly important. So, in summary, we're identifying these patients better. We're setting up specialist pathways for identifying and managing these patients. From these pathways come guidelines, but there's still a lot we don't understand. Thank you.